Okay, uveitis, anterior uveitis, or iritis. Symptom: if it's acute, you get pain, redness, photophobia, consensual photophobia, which is pain in the affected eyes when a light is shone in the fellow eye, excessive tearing, and decrease in visions. If it's chronic, decreased vision from vitreous debris, cystoid macular edema, or cataract. May have period of exacerbations and remissions with few acute symptoms. Signs: critical cells and flares in the anterior chamber, ciliary flash, keratic precipitates. Fine KP or stellite typically covers the entire corneal endothelium. Herpetic fuchs heterochromic iridocyclitis. Small non-granulomatosis KP. Human leukocyte antigens. Okay. Etiology: idiopathic, HLB27 associated uveitis. Systemic association include ankylosing spondylitis. Lens-induced uveitis, immune reactions to lens material. Postoperative iritis, which anterior chamber inflammation following an intraocular surgery. Chronic JIA, usually younger, may be painless and asymptomatic with minimal injections. Often bilateral. Okay. Herpes simplex or varicella zoster. Corneal scars. History of unilateral recurrent red eye. Occasionally, history of skin vesicles associated with decreased corneal sensations, increased IOP, and iris atrophy. Workup: obtain a thorough history and review of systems. 2. Complete ocular examination including an IOP check, gonioscopy, and a dilated fundus examination. The vitreous should be evaluated for cells. A laboratory workup may be unnecessary in certain conditions, in certain situations. If the uveitis is bilateral, granulomatous, or recurrent, and the history and examination are unremarkable, then a non-specific initial workup is conducted. Okay. Alright, treatment. Cycloplegic, for example, scopolamine 0.25% BID. For mild to moderate inflammations, atropines 1% BID for severe inflammations. Topical steroid, prednisolone acetate 1%, 1 drop Q1 to 6H, depending on the severity. Brand name is better than generic and often necessary. Most cases of moderate to severe acute uveitis require Q1 to 2H dosing initially. 3. If there is no improvement on maximum topical and respiratory steroid, or if the uveitis is bilateral and severe, consider systemic steroids or immunosuppression therapy. Consider referral to a uveitis specialist and rheumatologist. Note: prior to initiate systemic steroids or preocular deposit steroid, it is important to rule out infectious causes. 4. Treat secondary glaucoma with aqueous suppressants. Avoid pilocarpine. Glaucoma may result from cellular blockage of the trabecular meshwork, secondary angle closure from synechial formations, neovascularization of the iris and angle, steroid response. If an exact etiology for the anterior uveitis is determined, then systemic management is required. Ankylospondylitis often requires systemic anti-inflammatory agents. Follow-up: every 1 to 7 days in the acute phase, depending on the severity. Every 1 to 6 months when stable. At each visit, the anterior chamber reactions and IOP should be evaluated. A vitreous and fundus examination should be performed for all flare-up when vision is affected, or every 3 to 6 months. If the anterior chamber reactions has resolved, then the steroid drops can be slowly tapered, usually 1 drop per day every 3 to 7 days. For example, QID for 1 week, then TID for 1 week, then BID for 1 week. Steroids are usually discontinued following the taper when the anterior chamber does not have any cells reactions. Rarely, long-term low-dose steroids every day and every other days are required to keep the inflammations from reoccurring. The cycloplegic agents can be tapered as the anterior chamber reactions improve. Cycloplegic should be used at least every evening until the anterior chamber is free of cells.